is I will present the main lessons observed by the project throughout our work, and then we will open it for comments and discussions. As Professor de la Corte presented, we had a very large number of lessons observed. Out of each and every one of our meetings and webinars, we produced a document which is called Main Issues Identified Throughout the Call. And we compiled them, and we ended with more than 300 lines. And here I have to recognize the work of the colleagues in work package 4, of Peter Daly from Ireland, of Anna from the Norwegian Red Cross, of Natasha from Rinicon, the colleagues from Samur Madrid, who helped us look through these 300 lines and consolidate them to something comprehensive in the sense that first we had many lessons that were repeated, so we had to put them as one line. And on the other hand, we had some lessons that were right for their time and changed. For those of you who remember, 2.5 years ago, though it looks like ages, we were bleaching our equipment with 3,000 ppm of hypochlorite after every patient, or at minimum every 8 hours, and we were destroying equipment, vehicles whatsoever, and we realized that it was not needed, so we changed the disinfection protocol. So this is no longer a lesson observed, this is a lesson learned. It was implemented, let's move forward. The other component, which for us was the most important, was to look into all the observations that we have and look into the future, not into the past. One day, when I will retire in 500 years time from now, I will sit with the great grandchildren and tell them the tale of the pandemic. At the moment, we are in the middle of a crisis, and we need to learn, and we need to learn fast how to improve for the next time. And I have to say that this is one of the only fora I'm aware of, which is really doing this exercise during the pandemic itself, to try and improve. And I have to appreciate the time that all the colleagues here and globally have taken to participate with us in this important exercise, because at least in Israel, we are still in wave 5 and we're preparing for wave 6. And I think that if you look into the trends in Europe, Europe is also going into something not nice, let's put it this way. So this is the high time to see what we can improve. So we created a document and asked our partners to look into the lessons observed, use a Likert scale, and provide us with feedback. 0 if it's irrelevant, 4 if they think it is highly relevant for future preparedness, and going down. And my colleague Itamar from Agenda Vidadom is the one who did this wonderful work, and you can see here the distribution. I just want to say that we highly respect the views of the people in the field. And I strongly believe, and we as a work package believe, that there is room for a very wide survey of the perceptions of the people in the field. For the sake of this exercise, we did not look for the perceptions of the people in the field, but of the managers. And managers could be team leaders, directors in a ward, different levels of management, but management view on the issue. This is why the numbers are rather small. And we had 5 categories: the human factor, knowledge sharing, cooperation and coordination, equipment and supplies, standard operating procedures, what we call SOPs, and the issue of PPE, that yes, it supplies, but it was so specific for the COVID outbreak that we decided that we will put it as a separated issues, and you can see the number of items that people had to vote on. And I will present you the top 3. The winners are, oh, I should have said that after the last Oscar. The first one, which is the human factor, and human factor, I have to say, is the largest category and the one that has many repeated issues. This is how important people see it. And in the human factor, the winner is need for updated, trustful information sharing with personnel regarding everything to allow them a comprehensive understanding of the situation. COVID, at least at the beginning of the pandemic, was a roller coaster. We were changing guidance, protocols, procedures on a daily basis, not to say sometimes even twice a day. And we had to be very honest with our personnel, and personnel, I'm talking about all levels of personnel, including volunteers, because we had to be honest to say we have very little science. We are learning by the day, and whatever we learned last night is put into practice next day. And trying to convince them that we are doing the best we can, to the best of the knowledge that we have, to protect them, to allow them to treat their patients in an efficient way. That creates a huge amount of trust. I would call it a level of military trust that soldiers have in their commanders, because we were literally sending our people to the battlefield. And creating that trust, maintaining the trust, I think that this is one of our biggest challenges, that was a challenge and will stay as a challenge as this pandemic evolves. The second one is around PPE and around the need to run the stockpile, considering transportation, shortage space, and risk of throwing away out-of-date PPE. In 3 years' time, hopefully everyone in this room and globally will have a huge stockpile of PPE that will be outdated, sometimes will be stored in less than optimal conditions, and we don't want to throw away all that PPE. So we need to think about smart ways and try, I would say, to avoid the personal stockpile in my backyard and the competition over PPE. A global challenge for countries, for regions, for the years to come. In the third place, we had three. One is the capacity to create surge capacities in the hospital. I can give you the Israeli example. In Israel, every parking lot which is built in a hospital, especially those who are underground, and most of the parking lots are underground because of space issues, to start with, is built with the capacity to become an emergency underground hospital. Very easily, it turns from a parking lot to a hospital, and these parking lots were used to increase our bed capacity at the national level in Israel. Other countries may have other options. I know that countries deployed their field hospitals that are meant to be sent internationally as humanitarian assistance were deployed in country. Madrid used the capacities of Samur as an EMT to deploy in IFEMA. This is something that globally we need to look into as procedures. Fake news, I will come back to that. But fake news and the result increase in violence incidents against healthcare providers is a growing issue. We are even advising the policymakers to look into fake news as a global threat that should be put in the future in our contingency plans, and to start thinking seriously as fake news as a global threat, and what are the tools that we have to mitigate them. At the moment, let's be honest, we don't have them. And we cannot really track every fake news which is popping up on social media and interact with it. Knowledge sharing, cooperation, and coordination. We have the issue of the need to collect data, needs, gaps in lessons and preparation for future outbreaks. We have raised here the importance of data gathering and data sharing. We identified the issue of transparency of the data. We identified the issue of the need to convince our community, our general public, that we are transparent and we are sharing with them, and the challenges of combining data from different sources into one data set, one database that allows us to look into trends, emerging things. We have now the technological capacity to do that. We are not that good in collecting and sharing the data between organizations at the national level and at the global level. I would like to point out for us the importance of data sharing real time. Through the webinar of No Fear, we identified that there is a thing which is called silent hypoxia or happy hypoxia. For the non-medical people, I would say all my life I've been trained to treat the patient and not the monitor. And if the monitor says that the level of oxygen of the patient is low, hypoxia, and the patient is smiling, you have an issue with the monitor, not with the patient. For COVID patients, it's vice versa. They can be smiling, look okay, their saturation is very low, and they crash. And that was in the middle of nowhere, a change in the way we look into our patients, we treat our patients. And we managed to identify it very early. We managed to change our protocols very early. And I can say for sure that lives of Israeli patients were saved thanks to this real-time sharing. And I have to say, it was not a scientific exchange. There was not a research presented with p-values. It was colleagues. I think it was our colleagues, Christina, from your hospital that pointed out that you are seeing that. And I even remember the sign on your toilets. Don't forget your oxygen. And it was like, guys, we are seeing this phenomena. We think it's important. We are still collecting data, but just be aware that it exists out there. And for us, it was enough. And it saved life. And there are many small things that were extremely important in this exchange. And we are happy and thankful to the European Commission that No Fear existed when it happened, because we had this strong network that we can rely on during a pandemic, during a very stressful thing for us to exchange. And to be honest, we were dedicating an hour every week to talk to each other and exchange. And I will be forever thankful for colleagues in Spain, in France, in Italy, that in the middle of the havoc, and the only term is havoc, took the time to say, okay, guys, we are before you in the wave. This is what we are experiencing, be prepared. And Israel, that was 3 weeks ago, that was 3 weeks later in the wave, could learn, and we tried to share that with colleagues in the Americas that were even later, or in Africa. So for the human factor, I spoke about the information sharing real time. And fake news, already said. We need to provide people skills. And for us, this is one of the greatest challenges. Knowledge is nice, but people need skills. And donning and doffing PPE is a skill. It's nice to understand the process. It's another thing to have people confident. And by the way, donning is easy. You are clean, your PPE is clean. Doffing, when your PPE is supposedly contaminated, is way more complicated. So giving people the confidence, the skill is essential. And the need for psychosocial support programs for healthcare personnel, including volunteers, including the one-time volunteer, what we call the spontaneous volunteer, who is today with us, tomorrow not. And we really don't know if he's not with us tomorrow because he had a horrible experience over the phone line or doing some support at the hospital. And that's why she or he left. We need to support our people. We need to support our healthcare providers. The pandemic was a horrible experience. Israel is full of stories about a nurse holding a cellular phone in front of a patient to be intubated and telling the patient, say goodbye to your family, because there is a good chance that you will never speak with them again. And that's the goodbye of the patient from the family. And of course, there is a huge impact on the nurse, on the patient, and on the family. But I'm talking about the nurse and about the idea that that nurse could have done that 3-4 times in one 8-hour shift. And she wakes up the next morning, and the doctor and the paramedic, and they are waking up to the option that they will have to do it again 3 or 4 times. And the question is, how many times a human being will sustain such an experience? So even though as healthcare providers, we are not good in asking or seeking for psychosocial help, I have to say, we all need that. About knowledge sharing, I spoke about collecting data, needs, gaps, communication and coordination. And I will talk about our new roles as healthcare providers in a crisis situation. The main issue that all the healthcare systems in the world have globally is about sharing patient load. We all have these very bad images that we don't want to repeat of ambulances queuing in front of overloaded hospitals, waiting for hours for their patients to be admitted. We need to think of smarter ways of distributing patients. And I would like to remind everyone that distributing patients in France meant that patients arrived from across the Atlantic, from Guadeloupe, from Martinique. Patients were transferred in the train, in the rapid train, and patients were transferred all over Europe between countries, and team members were transferred from one country to the other to support the operation. So this issue of how are we going to distribute patients in a smarter way is, I think, one of the greatest global challenges, especially for the European Union, to discuss. Equipment and supply, the need for surge capacity is there. Stockpiling of essential equipment and creating this surge capacity at the organizational level is critical. And a central mechanism for stockpile management and equipment distribution. For SOPs, hospitalization overload. We need to look into the way that today, where antigen tests are everywhere, and you are positive, how do we evaluate our patients remotely? So if you are positive, a physician assesses your condition and takes the decision if you need to be hospitalized or not. Number one. Number two, sometimes you are positive and you have a regular emergency like abdominal pain. And I'm putting abdominal pain because abdominal pain requires a physician evaluation. It could be nothing, it could be serious. At the moment, for most of the services in the world, that means that you transfer the patient to a hospital. We understand that hopefully, most probably, this patient will be discharged from the hospital. So we created a problem that maybe technology can help us solve and do telemedicine, proper telemedicine for that patient, and allow the patient to stay at home. So we think that we need thinking about a new way with a high level of transfer, like Omicron or the BA2, which is out there. So we will have a lot of patients. That means that we will have a lot of issues with primary health care that we need to solve. We need to think about those patients. About PPE, the stockpile management was mentioned. User-friendly, environmentally friendly is an issue. The PPE that we are using is not user-friendly. It's hot, it's cumbersome, it's noisy. For those of you who have worked inside PPE, you know that all you hear all day long is the friction of the plastic. our patients, rightly so, expect to see our facial expression. 2.5 years into the pandemic, we still don't have transparent surgical masks that our patients can see if we are smiling at them or not. It should be there. The amount of plastic we are producing is not environmentally friendly. We need to think about other solutions on that. And of course, the need for enough stockpiles, enough size. And we mentioned here the idea that, talking about standardization, the fact that you might receive medical equipment or PPE with shipment documents in a language you cannot read because it's not English, French, or Arabic. And the idea that the size of the PPE comes with the country where it comes from. So a small in one country is an extra large in another, and vice versa. We should have standardization. If things that are way more complicated, like my credit card, are internationally standardized, PPE should be standardized as well. We just want to point out that we had differences between hospitals and non-hospitals. Just to give you an idea that solutions to increase workforce capability were very important for hospitals, but not for EMS. And we believe that that comes from the idea that hospital people were transferred from one ward to another, from one job to another, while in the EMS, it did not happen that much. And the need to prepare for other emergencies, again, is different. And just to remind us that during pandemic, we had 2 hurricanes in Central America. We are having now an armed conflict. We have a volcano eruption in Canarias and other emergencies during a pandemic. Under my additional thoughts are the issues that were discussed during our meeting yesterday and today as a project, identifying some issues that were not in our initial list, but we believe are very important. Care of staff and volunteers mentioned, but I would like to reiterate because it looks like the most important thing. And we will see a long-term impact. Some countries reported that 10% of their acute care health providers are quitting the business, especially young people, doctors and nurses who don't want to be healthcare providers anymore. This is the price that our healthcare system will pay in the coming years. For some countries, it is, as we say in my profession, acute on chronic, because they were short of personnel at the hospitals to start with. And now with more and more people leaving, it will become much more important. The need to recruit and shift personnel and train real time became one of the most important capacities that organizations needed during the pandemic. And we will have to see what we did well and what we need to improve. Again, thinking about knowledge and skills, and the idea that most probably knowledge is something that you can acquire remotely. Skills, it's not that easy. And we have to look into that. I would jump to the idea that we have 2.5 years that our normal healthcare system was providing suboptimal routine care, not just because we were stretched, but because people did not come to the hospitals. They were afraid. So we will see a long-term impact on chronic diseases, cardiac diseases, cancer, and others. That this is something that a price we will pay. It's important to say that after 2.5 years of management in a crisis mode, we are still in a crisis mode. But we should be shifting to the idea that this is going to stay with us as a new routine, and we need to start readjusting ourselves to this new routine. Many discussions about different models of business continuity. We had here in the room services that split their services completely between the regular services and COVID-related services, others that didn't. There are pros and cons to either solution, but how do we do our business in the right way in the years to come, understanding that the pandemic will stay with us, is still there. Technology. One of the most important things we developed, everyone almost in the room reported that they had apps to collect information, to share information. We used technology to share information with our staff and volunteers. We used technology for training, and the impact of all those technological tools should stay with us for the good, and of course improve what we need to do. The fake news as a new strategic threat was already mentioned. Consistency of messaging, something that we are always mentioning, and I would like to point out the colleagues from Ireland, that the only country in the world that I heard pick up a color, a horrible yellow, to say if we are messaging around COVID, whatever we are messaging, it's with that color. So the moment you see that color in front of your eyes, you understand that it is COVID related. A very simple thing that I'm sure had an extremely positive impact on the way people understand and identify the message. And messaging in the era of social media, I would say, is a great challenge. My whole life, I've been trained to do a press release, to stand in front of a podium and give a message. And then suddenly we realize that while the smart guys are in front of the cameras giving the message, people are tweeting, they're stupid, they don't know what they're talking about, facts are different, and it looks like that in many places, the tweets have more value than the very intelligent, well-prepared, well-allocated message you prepared. So we need to learn how to do crisis management messaging in disasters. And our last point is that it was put here very bluntly during this meeting. Crisis management is about industrial accidents, natural hazards, as we call it, things that we do. Pandemics are not considered in most of the countries as part of crisis management. They are a health issue. And for many countries, health is not part of the crisis management structure. We have civil protection, we have health people. Health people in many countries are not trained in crisis management. They don't speak the language of crisis management. And here suddenly they were merged together. Samur has a great advantage because they are both. They are the EMS of the city of Madrid, and they are the public civil protection. So they know the language, they know the people, they know the stakeholders. For many of us in the health business, this is not the case. And how we better integrate health and crisis management, we believe is one of the important messages that should come out of this pandemic. So that concludes my presentation, Professor de la Corte. I hand it over back to you.